Wonderful. Thank you very much, Rhiannon, and the rest of the team who've made this event possible. And welcome everyone to the first of the Hill's social mixers by Zoom. Some of you may have been to some of our physical mixers before. You've probably joined us at a variety of locations across Oxford to enjoy a glass of wine, some nibbles, and meet other people in the digital health community. Obviously, that's not really possible right now. And after much thought and communications with a number of you, we've decided to kick off our schedule of mixes again, but this time online. And what we're trying to do here is to really give you some of the experience of those physical mixers online. So, plenty of you go to seminars and webinars and, have lots of content thrown at you by Zoom or GoToWebinar or whatever else it might be. That's not the purpose of tonight. The purpose of tonight is to give you a nice and lively discussion to start things off, and then to move you into breakout rooms and into speed networking groups in order to meet the rest of the people in our community and hopefully make some useful connections. So I'll do just a little bit of housekeeping on that before we start. So if you haven't managed to yet, please edit your name to be your first name, last name, and then brackets your organisation. Obviously, one or two of you may not have an organisation, that's fine, you don't have to put one. But it helps people to find you and to understand who they're talking to and remember who they're talking to if perhaps they pop away from their screen if you've got that done. The way you do that is by clicking on participants at the bottom of your screen, then hovering over your own name, and that will then give you a more button, and if you sort of click that, you can go through to rename, and you can just rename yourself like that. If at any point you are confused or you're in a conversation you don't want to be in, or you just feel like you'd like to be somewhere else, then do feel free to leave a breakout room when you're in one, and Rhiannon and Adele and the rest of some of the rest of the team will be in the sort of reception area to help you out and to either put you in another room or help you with any technical difficulties or anything like that. So you're always free to do that. Obviously, unfortunately, you can't escape right now because this is the plenary session, and I'm super excited to welcome our panelists for this evening. Before I kick straight into the panel, I will just mention a couple of things that I want you to be aware of. One is that TheHill is currently recruiting for our Transformative Digital Skills in Healthcare course. So if you haven't heard already about that, please do ask one of the TheHill team about it at some point during the event, or we'll put some information up in the chat at some point as well, just so that you've got the information. But basically, this is a leadership course in digital healthcare, aimed mostly at clinical staff and managers within clinical institutions, but of relevance, I think, also to academics and researchers in clinical areas. And we've spent a lot of this year working with our international partners to produce the programme and to put together lots of very exciting use cases, many of which are based here in Oxford, and to bring the material to life and make it relevant to the people who are taking part. And so super excited that that programme is launching, and we'll look forward to talking more about it with you if you're interested later on. I'll move now into the panel discussion and welcome our wonderful panelists who have come to join us tonight. So I've got with me here, and you can probably see on the top of your screen, David Walliker, the Chief Digital and Partnerships Officer for Oxford University Hospitals. I've also got Trish Greenhalgh, Professor of Primary Care Health Sciences. I've got Andy Peniket, Lead for Innovation for the Cancer Centre at OUH. And I've got Mikesh Udani, co-founder and CEO of Albus Health, who are one of the companies that have been on our accelerator over the last 5 months or so. Now, can I just remind you all that if you haven't got your video off, if you could just switch that off at the moment so that anyone who's watching the screen can see just the panelists, that probably helps with sort of zeroing in on the person speaking at the time. The panel tonight is all about innovation, all about what we've done over the last 6 months during the COVID pandemic, and about how we can both take forward some of those innovations, but also learn from the things that we have done both well and badly, and move forward into a new era of digital health and care. I'd like to invite the speakers to each give a few minutes introduction so that you've got a bit of an idea about their background, about what they do as a day job, and some of the things they've been up to over the last 6 months. And then after that, I'll ask them a few questions. Once I've asked a couple of those questions and we've got the conversation going, I will open it up to the floor for questions. So at that point, it'd be great if you have a question, if you would just switch on your video and that's interesting. Switch on your video and you know, put your hand up, or you can type questions in the chat if you want to, and there'll be an opportunity to do things there.
Hi Megan, sorry, let me interrupt briefly to say, everyone, if you turn to speaker view, you'll only see the current speaker, and you can also, as Maxine's just posted in the chat, select to watch just video participants as well. So so you don't have to see everyone in little boxes. So sorry to interrupt, Megan.
No, that's absolutely fine. Technical advice is always welcome. Obviously, I'm not going to switch to speaker view, otherwise I won't be able to see when one of my panelists wants to say something. So, but the rest of you, yeah, excellent idea, please do. So Trish, can I start with you and perhaps invite you to give a bit of an introduction to your work, what you've been up to over the last 6 months?
Yeah, absolutely. So I'm a GP by trade, but I haven't seen a patient for a few years because I'm full-time academic and do a lot of public health work as well as general practice. But I'm also a social scientist, and for quite a long time, about the last 20 years, I've had an interest in the social science of implementing technology. Sometimes when people at parties ask what I do, I say I study failed NHS IT projects. That's not what I start off to study, but sometimes what I end up studying. And in the last 6 months, I've been doing a lot of work around COVID. Particularly, I got a grant from the UK Research and Innovation COVID-19 Emergency Fund for a study called Remote by Default, which is looking at the operational and clinical and personal and interpersonal challenges of this very abrupt, massive shift to remote consulting. I'm also running a learning set, or with my colleagues from the department, we're running a learning set for the Trust on introducing video consultation. So maybe some of you on the call know me from that.
Wonderful. Thank you very much, Trish. We really appreciate your time, as I know you spent a lot of time on Zoom already today. Andy, can I call upon you next to give your introduction?
So I'm Andy Peniket. I'm a clinician. I'm director of bone marrow transplantation at the TheHill. So look after patients with leukemia and patients who are very immunocompromised. And so obviously COVID for us has had a very big challenge. As you said in your introduction, I'm also lead for innovation within the oncology and haematology directorate at the cancer centre there. So part of my role there,
maybe you can pay it back. Yeah,
part of my role there is to try to encourage innovation, and as we'll probably be talking about, there has been a lot of innovation that's gone on over the last 6 months.
Fantastic. Thank you very much, Andy. Next, can I call upon Mikesh?
Hi Megan, thanks for having me over. Very good to see everyone. I'm Mikesh, co-founder and CEO at Albus Health. We're an Oxford University spin-out company, and we make systems for automated symptom monitoring at home. We make these small non-contact devices that can automatically monitor a range of environmental metrics as well as physiological symptoms without anybody having to do or wear anything. And because we're in the space of remote symptom monitoring, the last 6 months have been very eventful. We considered for a very long time what it would be to pivot to do only COVID-related work as opposed to doing the chronic respiratory work that we were doing. But we ultimately decided to stay focused, and in that journey, we've had quite a successful last 6 months. We were very fortunately recipients of the AI in Health and Care Award, which was announced by the Secretary of State for Health about a month ago. And we've also been a part of TheHill's Market Access Accelerator, have been receiving some fantastic mentoring and making good progress over the business. So yeah, as it's probably been for everyone, last 6 months has been an absolute roller coaster, but it's all now.
Fantastic. Thank you very much, and definitely making, and fantastic you got that AI award as well. I mean, that's testament to your hard work, I think. I'll call upon David to finish off the panelists, if I may. David, you're also on mute.
It's the curse of 2020.
First challenge overcome.
So I'm David Walliker. I'm the Chief Digital and Partnerships Officer at OUH. So for the last 6 months, it's been a crazy time, hasn't it? But from a role perspective, I have 2 jobs within the trust. So I have the digital piece, which I'll come back to, and then I have the partnerships piece, which is the strategy and partnerships development. And the last 6 months, from a strategy perspective, we actually wrote a new trust strategy January, February, March, had it approved at Trust Board in March, and then COVID came upon us. So actually, we've had to refresh that strategy because, of course, where we're planning to go to and how we're going to change our ways of working over the next 5 years are fundamentally different to our assumptions 6 months ago. So it was fortunate in a way that our strategy allowed that to happen. But that puts us in a frame and a where we're trying to get to. From a digital perspective, I think we've done more transformation in the last 6 months than what we were certainly expecting. So it's been a crazy few months. I mean, for example, we in March we did 2 video consultations prior to the surge planning for COVID. We did quite a lot of telephone consultations, but only 2 video. We're now up to between 4.5% and 5% of our outpatient follow-up appointments being done via video. But of course, that's not the answer for everybody, and it's not the answer for every scenario. But it at least allows a lot of patients to be seen in a different setting. And we also have had had to move about 3,500 staff at any point, or peak at point, to be able to access and work from home, which sounds relatively straightforward, you think, with modern technologies, but the wonders of the security that we need to wrap around that and to do it at pace. But we did, and so we went from maybe 200 concurrent home workers before COVID to now around about 1,500 to 2,000 concurrent users at any time, and that's across the full spectrum of clinical working as well. More innovation we've undertaken. We've done a retrospective into this as well to look at lessons that we can learn from it as we now plan for phase 3 of the COVID recovery. It was a lot easier to turn the tap off for activity than it is to return it. And of course, we've got to balance that off against any second wave of COVID. So at the moment, we've done an awful lot. We're taking a deep breath and we're trying to work out what we keep that was good, what we enhance, lessons learned from the last 6 months for the future, what's sustainable, and what we need to go back to. One of my worst terms just to finish off on that I can't abide is the term new normal. I think we should ban that from all conversations, and I think we need to understand what works for the patient and what's the right outcomes for the patient, because doing shifts in the way we work shouldn't compromise the outcomes that we're delivering, and that's the balancing act at the moment we're trying to work through.
Fantastic. Thank you very much, David. Now, if all the panelists would unmute themselves at this point, I think that might help our conversation, just because we're not going to then be sort of pausing while we wait for someone to come in. I'd like to pick up on that last point, which was about patients, actually, because I think obviously lives have changed significantly for everyone over the last 6 months. I think one of the things, Andy, for example, that I've been quite impressed with your work is the way that you've really put the patient at the centre of your changes to your service, and taken their views and considerations into consideration when deciding to do things like remote consultations. I don't know if perhaps you and then perhaps other people could also could reflect upon what do you think patients actually want, and how do you think the new innovations and new things that we've done as part of it have kind of benefited them?
Yeah, sure. So I think one of the advantages that we had in haematology is we had an outstanding patient-based quality manager called Katrina Gilmore-Hamilton, and she already had formed a patient group who were very well motivated. We were already using them in order to get feedback. In fact, she was really there partly for PPI, so if people had research ideas, it would be discussed with a patient group very early on. But we maybe came to it, if, you know, peak COVID sort of all kicked off at the beginning of March, but by April we realized that the panel was really important to us for understanding what we were doing. So there's the remote consultation, but a lot of this is, there's the Florence Nightingale quote about how the most important thing for a hospital is that it does no harm to patients. And actually with COVID, that was a really important thing for us. So we had to do all the remote consultations. We had to reduce the footfall within the hospital. And once we started consulting the patient panel, what we found was actually they had felt extremely reassured by what was going on. So the sort of things that we were doing were, we were doing temperature checking when patients were arriving. We were saying, don't come in and sit in the waiting room. Please wait, we will phone you when we're ready. Because there were so many remote consultations, the clinics were actually running on time. And hallelujah, there was no queue for the car park, which anyone who's visited hospitals, if you do a patient survey, a traditional patient survey, you get two things. They slag off the food and they slag off the car park. The food, I don't think we've got sorted out, but the car parking is definitely now being resolved really by the problems we had. So that gave us quite useful reassurance that the things that we had just decided to do because we felt we had to do them were more rushed. But then also that meant that, and I think that David and Trish will probably talk to this, suddenly starting to doing remote consultations without any training is not ideal. The huge advantage of COVID was that it meant that all the barriers that we'd had, we wanted to do remote consultations anyway. We were doing quite a lot of telephone consultations. We wanted to do more, but there was a barrier from staff and there was a barrier from patients because of conservatism and a general feeling that the face-to-face consultation was the gold standard. And basically, it's just been amazing to see how that's been totally broken down. But there's certain things that the patients have fed back to us that they want. They like it to be on time. They like to have the option. They like to feel that they can come for a face-to-face consultation. And there's these sort of things that we've learned. And the patient group's been very useful for feeding back to us immediately how we should be doing things.
Did you want to come in on that, Trish?
Yes, just to, I mean, this absolutely resonates with my findings, not just this time round, but every time we've looked at problems getting video consultations or any other kind of novel technology supported consultation up and running. But one thing I would put on the table for a bit of a discussion tonight is whether or not this is really about conservatism. Because one of the things we have found in the past, when either doctors or midwives or some other clinician resists the use of technology, it is not usually because of stubbornness. Sometimes it is. I met stubborn people. Mostly it is about professional standards of excellence. And we as professionals are highly trained. It's drilled into us. I used to teach on the professional development spine of, you know, the medical school. Actually, this is all about doing the best for the patient. In every consultation, you want to make sure that your care is high quality and safe. And what is happening with remote consultations is, I mean, before COVID, people didn't want to do them. They didn't want to do phone consultations or video because they said, well, it's not as safe, it's not as good. You know, actually, it's a compromise, it's second best. And often they were right. We worked in the East End of London trying to set up video consultations for patients with gestational diabetes. And the doctors and the midwives would say, well, actually the patient doesn't speak English very well. And if I'd like the patient to be in front of me just in case they get the wrong end of the stick. So what they were saying was they were feeling professionally accountable to the unborn baby that the mother was carrying and not just to the mother, to say, we've got to make sure that the care we give is top quality. So one of the things that has helped me when I'm studying so-called resistance to new technologies is to actually explore and unpack what it is that the clinician thinks is going to lower standards. And often it's quite subtle, and that's what we're studying. But it's very, very interesting, Andy, when you say, well, actually, when they tried it, they came round. And often that's because their concerns about being able to deliver high quality care, and particularly safe care. Actually, there are ways that you can deliver safe care, not always, but actually people didn't know that. And so it's a little bit of an oblique thing. The other thing to comment on actually is that the logistics of getting the patient in front of you, in front of their screen when you're in front of your screen, ready to have the consultation, the logistics are much harder than the actual consultation. So it's things like the virtual waiting room, the booking system, and also the kind of top and tailing at the other end. How do you get the letter onto the patient's notes? How do you get the letter to the GP? If they need an x-ray, who's going to pick up the form? All that kind of thing. Whereas the interaction by video is often the easy bit. I'll shut up, I've talked enough.
No, I think that you brought up some really good points there, Trisha. And in fact, we've been talking about, you know, it's all very well giving someone a remote consultation, but if then they have to come into the hospital for a battery of tests, or even just for a simple blood test, then suddenly you haven't really kind of solved the problem here, have you? Because they're still coming into the hospital, they're still, you know, clogging up the car park and all themselves at risk of infection, and, you know, the remote consultation doesn't really make sense. And so kind of, you know, solving the whole flow of remote consultation is really, really important. I'd like to bring Mikesh in here, because I wonder, Mikesh, if you've seen a change in attitudes in terms of, obviously your solution, I guess, has always been about in the home and, you know, remotely. Have you seen that this has become, you know, more popular or more acceptable, or, you know, that you've seen some encouragement of that approach?
Yeah, I think this has the push for remote monitoring has been higher as a result of COVID, and I think that intention will remain down the line. One of the challenges when we spoke to the clinicians right at the beginning, and we spoke to them before we knew what we were building, so we were just trying to understand what the problems were before we went out to build anything. And when we spoke to them, one of the things that we learned was that even if patients are coming in, one of the frustrations is that between two visits, it's very difficult to know what's happening with the patient at home. There was no way of reliably getting continuous objective symptom data when people were at home. And that was a problem even when there were face-to-face consultations. For chronic conditions such as asthma, for example, where some of the early warning signs might come up, but they're always missed because patients don't perceive them, and when patients are at home, clinicians don't know what's happening. So there was a rationale for bringing this in, but it's been that rationale is even higher now that everything is happening, or at least there's a push to do it remotely. I'd also like to build on one of the points that Trish made earlier about sometimes there is resistance, but it's for the right reasons, and not every technology that is built is suitable, and you know, technology just for the sake of technology is probably not a great idea. And generally, we felt that for any healthcare-based innovation or intervention, it's very important to include all the stakeholders, so patients, people who are delivering healthcare, the people who are paying for healthcare, all of them at a very early stage of the innovation. So their requirements and their suggestions could be included right from the start. It's probably not a great idea for engineers to lock themselves in a room and just decide what the next healthcare innovation should be, because they might miss a lot of important insights that come from patients, their families, from clinicians, nurses, the regulators, the NHS, all the different stakeholders involved.
Yeah, absolutely right, Mikesh. I think it's a systematic innovation, isn't it? Anything that goes into the healthcare system is not a standalone innovation. It's very much got to work with the system it finds itself in. One of the things that I reflect upon over the last 6 months is that, you know, we have had an awful lot of innovation very quickly. I mean, David was mentioning, you know, how many video consultations we do across the trust now, which we wouldn't, you know, barely did at all at the beginning of this pandemic. Do you guys have some reflections on kind of what we will keep and what we might actually get rid of as well? You know, whether there are things that have come to pass that we think actually this is for the duration of the pandemic only, and really we don't want to do this, and we'd like to kind of roll back on that. I don't know whether you've come across things like that. David, would you like to come in on this?
Yeah, I mean, the easy one to pick is the video consultation. But before I answer that, I'll just loop back to the previous conversation point, because I think it is important. I think Trish is correct. It's not a conservatism piece, but we've also got to accept that the public sector, not just the NHS, but the public sector is also not listed with successful deployments of technology necessary to reach and as used as a mantle. So I think we're in a unique position in March where we had a bunch of clinicians uniting behind a common purpose. Medicine is probably the most personalised profession. No one wants to lose that piece. But if you looked at the risk transfer of not see anybody or see them via this new technology, and the patients wanted to be seen as well and understood. So actually it created a culture whereby I think the patients were accepting a little bit rough around the edges of the product because they could still be seen, and the clinicians were a little bit more able to deep into, jump into it because they were aware it was going to, it was new. And I think everyone got right behind it. The question now is to make that sustainable, that people won't be accepting the rough around the edges pieces in the future. So we do need to perfect it. We can't have a clinic that's set up just to be video consultations. So we need to have this seamless connectivity between video consultation solution and the scheduling system. So whether the clinician's calling in a face-to-face appointment or a video appointment, it should be seamless for the clinician, because we don't want to add burden. And as Trish said, the administration overheads to that are quite significant. And I think the patients then will, expect it to be a little bit more slick, a little bit on time. So I think we will keep the video consultation, and I think we'll grow it. And I think there's probably more opportunity as well to do more group type therapy meetings on video, perhaps, for cohorts of patients where that's suitable. I think my personal thing, the one thing that I think we should do less of is actually a process question rather than a technology, but it's being brought about because of the technology. And that's now because we have staff working remotely, which again was novel for some people 6 months ago rather than normal. I don't think our practice and behaviours have caught up with that. So, not for the world's smallest violin, and it's not so I can compare with Trish, but this is my 10th video meeting today. It started at 7:30 this morning. It's going to finish at 8:30 tonight. We're going to all burn ourselves out if we continue to do this. And there's a process and cultural behavioural piece that needs to follow the technology now. And I think we need to try and marry those two things up. So I would like us to lose the belief that because we're doing everything on video, we're productive, because actually, I don't think we are.
Yeah, I think you're absolutely right, David, that there's a huge amount of things in terms of process. And yeah, I've been on video calls since 8 o'clock this morning as well. And it's very efficient, but not necessarily very good for us, I think. So we have got to watch out for that for sure. Does anyone else have any reflections upon kind of, how we should go about keeping innovation and kind of what we need to do to kind of put those, I guess, rub off those rough edges and keep the stuff that's really good, such that we can kind of move forward into, if you like, a new dawn and take a great step forward in the digital space. And I don't know, Andy, if you have a reflection on kind of, will your patients want you to continue with some of the stuff you're doing even?
Sure. I mean, I think that in our practice, we often have patients coming from quite a large area who need multiple consultations. So some of the challenges of getting that rapport with the patient, it's very easily transferred because we've already got those relationships. And certainly, I think there is a big role for a face-to-face consultation. So I think that, but most of it can safely be done remotely. I think the big thing, and I'm going to be very interested to talk to Mikesh about this, and then again in the future, is that although we can talk to patients, monitoring their physiology at home remotely is not something that we're doing anything nearly enough of. So we do one thing with our patients, which we give them a thermometer to check their body temperature, and that is it. And it's not really enough at the moment. And certainly with COVID, we almost were giving people pulse oximeters to take home. We didn't actually start doing that, but that sort of this very really basic thing is clearly something. I suppose actually patients do check their own blood pressure if they happen to have bought something off Amazon or the GP's lent them a machine. But I think we're going to move into the physiological monitoring. And there is something else as well, which is the whole thing about patient-reported outcome measures and the patient's symptoms, and getting them to, if we're going to be using this IT, how we can use that. So I think it's going to be an expansion of remote monitoring and also recording of the patient's symptoms, which we can now do as we go more digital.
Thank you, Andy. I'd like to open this up to questions from the floor, because I'm aware that we're having a great chat here, but there's lots of other people out there who I'm sure really want to get involved with this very interesting discussion. I've put a couple of questions in the chat for people. So one about, is reluctance to adopt new innovations about a lack of understanding of technology or a concern about quality? And I think that speaks to that sort of conservatism point. And then also, what process changes need to be put in place to make room for new innovations and capture the benefits without the negatives? Because I think that is also a really key point of today's discussion, is that it's not just about implementing Microsoft Teams and then off you go and yada yada, everything shall be golden. You need to think about, well, how does that fit in with your processes? How does that fit in with the way you interact with people? How do you make sure that you don't then end up on video calls for 10 hours a day? And how do you capture the benefits of that without some of the downsides? So, question. You could just switch on your video, or you could put up your electronic hand, or you could put up your real, switch on your video and put up your real hand. Probably switching on the video is a nice way to do it, because then you get to see your face as well, so that'd be fantastic. And Tina, I noticed you have, and you posted stuff in the chat, but maybe would you like to sort of say a few words and ask the question now?
So we've been through this in Sweden. The Repair is a Swedish company, and so resistance to change, it's not unique to the UK. But what we found really helps, and what we need to do as suppliers, is we need to help our healthcare professionals make that change. So changing the patient pathway, like you say, it doesn't happen overnight. Switching a face-to-face consultation to a video isn't going to drive the efficiencies that you need whilst increasing patient care. That's just not going to happen. Where parts of digital fit in. So it's not a particular patient, it's not a particular type. It's unique, and it should be there as a tool in the healthcare professional's toolbox to use. And I think as suppliers, it's kind of our responsibility to help with that.
Fantastic. Thank you very much, Tina. And Tina is another one of our fantastic companies on our accelerator program, which will be graduating. It's been fantastic to have you. Trish, did you have a response to that?
Yeah, just to say that one of the things we've been doing in the learning set, and actually also with some groups outside the learning set, is process mapping. And there's a couple of people who are employed by the trust whose names escape me, very nice blokes, both of them, are helping with the process mapping. It is unbelievable how complex it is. It's just to go to for example, the chest clinic for asthma or something like that. So you've got to go and have an X-ray, you've got to go and have your lung function test, you might have a blood test. And if you actually map out the patient journey, you then realise why it's so clunky logistically. And the patient doesn't magically pop up because they've actually got to have all these 28 different encounters. So process mapping, it takes a while, but once you've got it right, it will work, hopefully. So just to say, get yourself some process mapping software and play around with it.
And you don't even need too much in the way of software, although my team will probably disagree on that point, since I've been playing around with Marrow, and I tell you what, the diagrams are not pretty. But no, I think you're absolutely right. Current services are quite fascinating, and it does make you realise that maybe a bit of innovation in how you simplify them and do something a little bit differently is definitely relevant. I noticed, Luke, that Luke O'Byrne, you've been posting quite a bit in the chat. You've got a good example there of Skype A&E mental health assessments in Oxfordshire. and sort of talking about the digital director working with lead clinicians. I don't know if you wanted to come up and pick up on any of these points in the video stream. I don't know if you're able to switch on your video and come and join us for a moment.
Megan, I think for me, the rolling out of the practice is really important. So you get the change that happened in the A&E mental health assessments in Oxfordshire, but then people seem to go through it in every specialty and every trust up and down the country, and it's trying to think how we can get that that innovation rolled out much more widely and much more quickly. So the process mapping stuff that Trish just mentioned, I think is really important. We did a lot of work on it in mental health trust where I worked, but we found that the ideas were necessarily transferring across the trust and outside the trust. So I think we've got some real challenges within the NHS about getting stuff rolled out systematically across across.
Yes, I think you're absolutely right, Luke. And Mikesh, I don't know if you've experienced this in terms of, obviously you're bringing in a solution which is in a sense outside of the normal structure of the NHS. You know, it's obviously in your startup company. How have you found navigating kind of who exactly should be buying your solution and how you might, you know, who you're going to align yourself with in order to get that rolled out? How has that been?
It's been very challenging. It's not been simple. And when Trish says it's complex, I 100% agree. It is complex, especially for me, for example. I mean, until about 3 years ago, I didn't have any experience in healthcare, let alone UK, anywhere else. So the process mapping is very important. How we are doing it is, so we starting a clinical study at Imperial College, Royal Brompton, and at Birmingham. And the process mapping is the first thing that we're doing. We're understanding what happens in the patient journey for people with severe asthma when they go through secondary healthcare. What are the different touch points? What are the bottlenecks? Where is it necessary for them to come in? Or where is it slice and remote monitoring? So process mapping is absolutely the first step, even before we start our clinical study. In our clinical study design, while we're in the protocol stage, we are doing that and then that will decide what outcomes we see, what impact. To help with this, we have included clinicians, of course, respiratory researchers, but also the head of IT. We've included the service managers. We've included people from the management in the hospital, as well as there are patient representatives. Asthma UK is a part of it. We're going to include the parents of children. So all of them are going to be involved in helping us understand each part of the process, and that will be our starting point throughout this project, and that'll be these are the people who we will involve throughout this project.
Yeah, it's a big thing, isn't it? Absolutely. I've noticed that Ido's got his electronic hand up. Ido, did you want to come in and join the conversation?
Yeah, I just wanted to pass a comment about innovation. I mean, being a clinician, we are all very good in introducing changes or city or because the situation is quite urgent. And what we often forget as clinicians is to actually start collecting evidence as we go along that the innovation is actually effective and has actually done what we wanted it to do. And I think most organizations don't have a robust system of facilitating that data collection to say an innovation is effective, because clinicians sort of struggle along the way and don't have that expertise or support to come up with some that the innovation is working. And we don't have the time to build on, and we just introduce a change, get along with what we need to do and to look after patients. So we need to slightly think bigger in terms of how clinicians and various clinical teams can be supported at a very short notice to be able to come up with some robust measurements that they can prove that the innovation is effective, and that's how you will be able to convince those who actually resist the innovation.
I think it's time probably for us to move on to the next part of the session, but before I do, David, did you want to come back on and mention anything on that comment, or kind of perhaps wrap up by just saying a few words about what might be the future of innovation in terms of the next 6 months and what we might hope to see going forward?
Yeah, but I can give my personal opinion on this rather than necessarily a professional opinion. But I think, you know, one of the things that we need to start doing more of is to transform, you know, I'll take, you know, ophthalmology is a nice example to use. So before COVID, patients would come in for their ophthalmology appointment, normally with somebody, causes the traffic problems on the John Ratcliffe site that we touched on earlier, to come for an appointment in a waiting room that wasn't really fit for purpose, to be seen, to come back. So first of all, the model was never particularly human-centered and effective. It wasn't a good experience for everybody, but that's the way it was configured. We would like to do more of those appointments somewhere else. The issue of ophthalmology is that you need diagnostic imaging to undertake a lot of those appointments. We've got a challenge now where the waiting rooms can't see as many people because they have to be COVID secure. People still tend to need to be brought there. If you're going to have something done on your eye, you tend to need somebody to drive you home. So could we do more in the community? Well, yes, but to do more in the community makes a system reconfiguration challenge, because we've got to purchase different types of diagnostic imaging to put in different types of places to be able to have an effective diagnostic appointment. And I think what we need to be doing over the next 6 months is addressing those sort of challenges from a system perspective. So it's not about OUH, it's about the patients and populations of Oxfordshire and what's the best outcome for them and how do we provide those services. And then look at where does technology and innovation sit on top of that to enhance the patient experience. And, you know, remote monitoring, I think, is definitely one, because we either would like to be monitoring people before they come into hospitals, see if they've got any of the predeterminants of COVID before they come in, or if they, you know, heaven forbid, but we are entering winter, that our beds fill back up. We would like to be able to discharge people earlier as well, safely, in case of event. But I think what we also need to do is look back and remember that the patients are at the centre of this. And I think we need to look at system research as well.
Fantastic. What a note to end on. Thank you ever so much to all of our panellists. I would ask everyone to give you a clap, but I've tried this in the past, and frankly, it's absolutely terrifying on Zoom. So if anyone does wish to use the little icons, do feel free to kind of say thank you ever so much to our panellists. We really appreciate you coming along and giving such a great discussion.